to where I can see my PowerPoint. Right. Okay, so just a quick mention, we're of course not doing on-site labor and delivery tours right now. So if you're interested in seeing kind of what the rooms look like and all of that, you can email me or you can call me, and I will get you set up with the link to the virtual labor and delivery tour. The tour shows you 3rd and 4th floor. It's been recorded prior to the whole COVID-19 thing, and so it does not take into consideration the restrictions. So it does talk about our normal visitation and all of that. Right now, for our laboring families, moms can have partner and then one additional coach with them for labor. So that's good because we were just allowing one partner with you. So as things get better, I think they will start opening that up to additional visitors. But right now, we don't allow any other visitors for our families. No children, especially no children under the age of 18, unless they're there to get medical treatment. So it's pretty strict still, but we are having a little bit more support during labor, which is a good thing. All right, so just a quick talk about anatomy and physiology and how pregnancy affects our bodies. I know you guys are familiar with this. Most of you are in your 3rd trimester, and you know that this beautiful little alien growing in your belly is shoving all your internal organs around. It can cause a variety of different discomforts. I'm going to focus in on a couple because they are most prominent now. Loose joints can happen during the 3rd trimester. This is caused by a release of a hormone called relaxin. And relaxin is a good thing. It allows our ligaments and tendons around our pelvis to stretch and help our pelvis to open up better so that when we are in labor and we're pushing, we can actually deliver that baby through there. But it will start in the 3rd trimester. The further along you are, the more relaxin you have flowing in your body. And so I know you guys have all seen the pregnant woman that is walking around like, you know, she's just really wobbly and like her joints are just not connected anymore. And that's due in most part to relaxin. So if you've got previous injuries, you know, you have joint injuries from the past, they can become a little more problematic when that relaxin is flowing in your system. So, you know, it's not fun, but it's a good thing. Okay, and I see a question. I will try. I'm still figuring out how to get the recordings out. I haven't figured out how to do that yet, but I will absolutely give it my best shot because I've got to figure that out. So I will send that recording if I can get it figured out. Sorry, my phone is going crazy. Okay, it's just emails. All right, so the other thing I wanted to mention is round ligament pain. Round ligament pain can be really scary. It's not there's no problem. It just hurts. It feels like a stabbing pain in your side, or to me, I always thought, gosh, it feels like my ovary just exploded. But it is a spasm. The round ligament attaches to the top of your uterus, which is your fundus. And then it attaches to your groin. And as that uterus is stretching and expanding, it's pulling on that ligament and it makes it very cranky. And so it will spasm, especially if you have sudden movements, you know, a cough or a sneeze, or you turn over in bed, it can cause round ligament spasms. So the best thing to do is if you're having a lot of that, to reduce your activity level. You know, if you can, go lay down for a little while. Getting in the shower and allowing that warm water to help your body to relax may help to reduce the round ligament pain. You know, just things that will help you to relax will help this. I mention it because I don't want you to be scared. You know, you can think, oh my gosh, something just happened to my baby. But it is absolutely just that spasm of that ligament. Exercise is very important in pregnancy. You of course don't want to start any rigorous exercise routine. If you're a couch potato and you're thinking, oh gosh, I've got to get really, really in shape, and you start heavy exercise, it can be problematic. But if you were an athlete prior, or, you were somebody that ran every day, or, had a really regimented and, disciplined, and like myself, exercise routine, you can continue that in pregnancy. You just always want to mention it to your doctor and make sure that there's not any reason to, reduce your activity or anything like that. But exercise actually helps you to prepare for labor. If you have not any activity in your body before you go into labor, labor's going to be more strenuous for you. It's called labor because it's hard work. It's like running a marathon, and you wouldn't run a marathon without training for it. So what's recommended for those of us who are not super active is to walk at least 30 minutes a day. If you can't work your way, or if you can't, start out doing 30 minutes a day, then you're going to work your way up to that. But 30 minutes of walking will make a huge difference in how well you tolerate labor. It improves your cardiovascular health. It improves your ability to breathe. It helps with all those ligaments and tendons and muscles that you're going to be using in labor. So you want to be able to be in the best shape possible. So walking is your best bet if you're not already in a routine exercise plan. I have mentioned a few other things that can be helpful here. The pelvic tilts can help stretch those ligaments and tendons, especially around the pelvis. They can also relieve a lot of back pain that's related to pregnancy. And if you've never done a pelvic tilt, they're sometimes called cat-cow stretches. If you do yoga, sometimes they call them that. But basically, you're on hands and knees, and you are stretching and arching your back like a Halloween cat with your head down. And then you will sway your back like a cow and put your head up. And you do that, like a set of 10 or something. And as you're doing that, it helps to manipulate those tendons and ligaments around your pelvis. It helps to take pressure off of your lower back. So I found them helpful when I was pregnant, and actually even now I do them pretty regularly as a part of my stretching routine because it helps with my lower back. I have back issues. Squatting, anything that helps to open the pelvis will help when you're in labor. And you may want to do squatting when you are in labor because that helps to move that baby down. Babies do this internal rotation to get into the position that they need to be in for delivery. And the more you can open that pelvis, the better. So squats, lunges, things like that will actually help with that baby's internal rotation and getting into that labor position. So practice squatting. Of course, if you have any preterm labor issues or you have a cerclage or something like that, you certainly don't want to be squatting because it does put a tremendous amount of pressure on your cervix. But assuming normal healthy pregnancy, which this class assumes normal healthy pregnancy for everybody, then you can certainly do squats and practice squats when you are in, preparation for labor. Squatting, you don't have to start out as a full squat. You can do a modified squat. You can do wall squats. Birthing balls are wonderful. If you don't have a birth ball, I recommend them. They're an exercise ball. Don't pay for something called a labor ball because they will charge more for it. Just buy an exercise ball off of Amazon, or you can get them at Walmart or Academy for like $10. But just sitting on a birth ball is a squat. You can do lunges using the birth ball as well. You can do a lot of different motions. You can sit on the birth ball and kind of do figure eights with your pelvis, and that helps with strengthening and stretching those ligaments and tendons. You can sit on a chair, you can sit on a toilet. Those are squats as well. So anything that you can do that is like a squat helps to open that pelvis up. And ladies, you guys have a big flexible pelvis with lots of joints in it because we have to deliver these babies through there. And you can open your pelvis, the outlet where the baby is going to come out. up to 30% more when you're in a squat. So that's why they're beneficial when you're in labor and when you're pushing. Kegels, those are difficult to show, but I can explain them. Pelvic floor exercises is another description of those exercises. The bottom of your pelvis, there's a basket of muscles, and those are kind of holding everything up and in, and the stronger they are, the better for pregnancy and for labor and for later in life. If we have a good, strong pelvic floor, it prevents a lot of problems later on. We can develop incontinence of both urine and bowel if we don't have a strong pelvic floor. It also is just really beneficial to have a good, healthy, strong pelvic floor when you're in labor. Kegels, in order to learn how to do them, you can sit on the toilet and urinate. And when you stop the flow of urine, you're using the same muscles that you will use when you're doing Kegel exercises. So that's how you find them. I don't want you to do them while you're trying to urinate, because for one thing, there's somebody else in charge of your bladder right now, but also if you do them when you urinate, it can actually weaken the muscle. That's just the way you find the muscles you're looking for. But Kegels, I send out in your handouts an information sheet on Kegels, and it talks about the benefits of it. It's beneficial for men too, actually. But you tighten those muscles, hold it, and then you release. And then you do, like a set of 10 of those several times a day. It's going to, over time, strengthen that pelvic floor and, help those muscles be well oxygenated. Have a trigger, like when you talk to your mom on the phone, or, when you're at a stoplight or whatever, you can remind yourself that you need to do 10 Kegels, and it will benefit you tremendously. And you'll continue to do those as a part of your recovery, and hopefully later on, and as you're continuing in life, you'll do Kegels so that you don't have those complications I mentioned. Tailor sitting is another one that you can do. You're going to be in all different kinds of positions when you're in labor, and the more stretchy you are, the better. So tailor sitting is you sit on the floor with your legs in a V, and then you stretch over a leg, over the center, and then over your other leg. It will help to stretch all those muscles and ligaments in your legs, and that will make it much easier for you to get into those different positions when you are in labor and when you are pushing. I think we kind of have this misconception in our culture that when you go into labor, you lay flat of your back for the entire time. If you do that, you're going to be more miserable. It's going to be more painful. You're going to have a much longer labor. So I want to break that conception now, and I want to put in your mind that you need to be changing positions frequently when you're in labor, every 30 minutes to an hour. It will help your baby to be able to move down and get into position for labor. It's going to help shorten your labor. It's going to make you more comfortable and make you feel like you have more control. At least every 30 minutes to an hour, but anytime you're uncomfortable, if you can kind of cue in and listen to your body, it may tell you a position that it wants to be in. So practicing all those different positions. And I sent out my practice labor station cards that I use when I actually get to have classes in person. And that has a variety of different positioning that you need to be practicing so that you can be doing that when you are in labor. So I encourage you to look through those. And they're pretty well detailed, but if you have questions about them, please let me know. I know it's really different to learn it from a card than it is to learn it from someone in person. So let's talk a little bit about when's the best time for these guys to be born. We want our babies, of course, to be as healthy as possible. We want our mommies to be as healthy as possible. And I've been a nurse for 23 years. And when I first started in nursing, we thought that all you had to do was get babies to 37 weeks. And then, they didn't really do much except for get fat after that. And that's really not true. March of Dimes was looking at the outcomes of 37-week babies and earlier, and realizing that they did not fare as well as a 39+ week baby. And they did put a lot of research into that, National Institute of Health also. And they came up with this campaign called the 39 plus weeks campaign. And so I encourage you to look at the NIH's website. It has lots of information about it, but basically what it boils down to is babies have better lung, brain, and liver development at 39 plus weeks than they do prior to that. And that gives them a better chance to transition easily to extrauterine life. And we have to intervene far less as medical professionals. But if you look at a 39-week brain of a baby versus a 35-week brain, the brain of a 35-weeker is very smooth. It doesn't have all those folds that we think of as what a brain should look like, whereas, 39 plus, they've got those folds. And those folds basically translate to maturity. So the earlier, the less mature. It just totally makes sense, right? But the lungs also are not producing the product that they need that help hold the air sacs open. So it makes it much harder for them to breathe if they're early. So we like to get them to 39 weeks if at all possible, but if you have a medical condition, pregnancy-induced hypertension, gestational diabetes, intrauterine growth retardation, the baby's not growing like they should, placenta is looking calcified and ineffective, then there's lots and lots of reasons to deliver before 39 weeks. But if there's not a medical reason, then we want to make sure that we are delivering those babies when they are ready. And actually, it really is best if we can wait until it's your body's idea. Your labor will be far easier and usually shorter if we wait for labor to start on its own. But that's kind of a side note. When it comes to 39-week plus deliveries, moms have better outcomes as well. There's less incidence of C-section, less incidence of postpartum depression, or postpartum mood issue. So everybody benefits if at all possible, but of course, if there's a medical reason to deliver early, then that's a whole different ballgame. So let's talk a little bit about preterm labor. Preterm labor is all the signs of labor, some of the signs of labor, any signs of labor prior to 37 weeks gestation. So if you're having 6 or more contractions in an hour, you have that low backache that's worsening rather than coming and going or getting better with position change. Menstrual-like cramps, pressure in your pelvis, or an increase in your vaginal discharge, especially if it's bloody, then those are signs of labor. If your water breaks or you think your water breaks, then that's the deal breaker. You got to head to the hospital no matter where you are in your gestation. It's very rare for your water to break early, but it has happened. It does happen. So if you think that your water has broken, then we need to check you guys out. Sometimes we, like I said earlier, we have someone else in charge of our bladder, and sometimes we pee on ourselves and we don't really know if it's amniotic fluid or it's urine. We can check it, so head on into the hospital if there's any inkling that your water may have broken. They'll swab and see if it's amniotic fluid or not. And if it is, then of course we need to be looking at monitoring and checking you out and checking baby out. And we want to, make sure that we're doing everything that we can for you. If it's not, then, no big deal. You just head on home, right? But if you're having these symptoms, a lot of times it means that you're not really paying attention to your body. You're not really stopping and caring for yourself. One of the most common reasons for preterm labor is dehydration. So what we want you to do if you start to have some symptoms of preterm labor is stop what you're doing. We're usually rushing around. We're trying to get ready to leave work for maternity leave. We are trying to get our house ready, and we don't stop and rest. So you stop what you're doing. You're going to go empty your bladder because your bladder and your uterus compete for space. And your uterus can get really grumpy if your bladder's taking its space up. So it will start contracting. And then you want to drink fluids, preferably water. 4 to 6 glasses of water, and you're going to lay on your left side, or, if you can't lay on your left side for some reason, you can lay on your right. But laying on your side helps to improve the oxygenation to your uterus and to your baby, and the blood flow to your uterus and your baby. And that usually, if you do these things, it's going to stop your preterm labor symptoms. Okay. If they don't disappear after you've done these things, then you need to call your doctor immediately. Okay. Most of the time they'll have you head on in for some monitoring. So just keep in mind, it's best to take care of yourself all of the time. You need to be eating well, lots of different foods that are healthy, not junk food. You want all those vitamins, minerals, building blocks, protein, calcium. If you're not caring for yourself, then it's really hard for your body to do the thing that it needs to be doing, which is creating this life. So you're important, okay? So don't forget to eat and drink fluids and take care of yourself. All right, so when do you call your doctor? Bright red vaginal bleeding is a red flag. If you are, especially if you are not in labor, okay? It's not normal to have bleeding. When you're in labor, you are going to have some vaginal bleeding. It's called bloody show. And as that cervix is opening up, it seeps blood, and you will have increasing bloody show in labor. But anytime that you're not in labor, we don't want to see bleeding. Okay, so bright red vaginal bleeding, especially if it goes in line with that third one down, the severe abdominal pain. If your abdomen is hard, it's not like a contraction that comes and goes. It is hard and it is painful, then that is a sign of a pretty severe complication. You need to get checked out right away, especially if it's coupled with that bright red vaginal bleeding. Now, if you don't feel the baby move in a long period of time, I included a fetal kick count chart in your handouts, and sometimes we're busy and we don't really realize what's going on. We're not paying attention, not really noticing when the baby's moving. And then when we stop and sit down and we start paying attention, that baby's in a sleep cycle. They do sleep in there 30 to 45 minutes at a time, and we kind of freak out because the baby's not moving. So if you don't feel the baby move in an unusually long time, we recommend that you go get something cold and sweet to drink. You're going to lay on your left side, and you're going to pull out that fetal kick count chart, and then you start counting bumps, splitters, kicks, whatever the baby is doing in there. Usually within 10 minutes, you will have felt 10 movements. But if you go through the fetal kick count chart and you don't feel movement, you need to call your doctor right away. Most of the time it's us being hypersensitive and over analyzing things, and it's no big deal. But if you don't feel the move after you do the kick count chart, we need to get you in and get you monitored and see what's going on. Sudden and severe swelling is a complication of pregnancy-induced hypertension. We monitor for that every time you go to the doctor, but sometimes it comes on suddenly. So if you see this change, and I'm not just talking about your feet swell at the end of the day after you've been up, it can totally be in your legs and your feet, but it's usually more pronounced than just in your feet. It will be pitting edema. If you push on your shin, there'll be a dimple left behind. If you look at your face, it's very puffy and swollen. Your hands may be so swollen that you can't tighten them to make a fist. I had pregnancy-induced hypertension with my first child, and one day I could put my watch on and I could snap it, and then the next day there was no hope for me to snap that watch. It was that big of a change just in 24 hours. I've seen women come in that have been so swollen they can't even really open their eyes. They kind of look like the Michelin Man. They just are very, very puffy. So if that happens, then there's been a change your doctor needs to be aware of, and you need to call them right away. Pardon me. If you're sick, you of course want to call your doctor. We're hypersensitive to that right now because of COVID. You certainly need to be calling your doctor if you're running fever, you're having low, like body aches, that kind of thing. It's just common sense to call them anyway whenever you're sick. So make sure you let them know if you're sick. And then sometimes you don't know what's wrong. You just feel like something's wrong and you can't put your finger on why. That's okay to call your doctor. I didn't realize until I became a childbirth educator how afraid women are of their doctors. But they're there to help you through this, and they're there to answer your questions, and they're there to treat you when you need medical intervention. So don't be afraid to ask them questions. You know, you can call and leave a message for their nurse, and the nurse can call you back. Sometimes you just can't put your finger on it, but something feels wrong. And, you know, sometimes it's nothing, but sometimes it is something. And it's okay to let them know that you just feel like something's off. You know, and if it's not something that's pressing right that moment, but you have a question, write it down. I never remember if I think, oh yeah, I'll remember to ask that later. I never do. So have a little notepad that you write down questions for your doctor on and take that with you to your visit. And then, you know, of course, this class is focused on normal, healthy pregnancies. Your doctor knows your health history, and so they may have a different set of reasons for you to call them, you know, based on your own health. Nothing that I say in this class should usurp what your doctor instructs you to do. So make sure that you are following their instructions. Okay. So let's talk a little bit about how you know if you're truly in labor. There are such things as Braxton Hicks contractions or practice contractions. Those will also start in the third trimester, and a lot of women don't notice them. A lot of women find them very uncomfortable, so it can run the gamut as to how you feel about your Braxton Hicks contractions. Braxton Hicks contractions are not true labor contractions in that they are not going to cause changes in your cervix. They are not going to become regular. They're not going to get longer and stronger. When you rest, a Braxton Hicks contraction pattern is going to go away. Okay, and they aren't. Pattern is a misnomer. I shouldn't say that. Braxton Hicks contractions never get into a pattern. Okay. You usually feel them in parts of the uterus, but not the whole uterus. So a lot of times they'll start at the top of the uterus and work their way down towards your groin. Whereas true labor contractions are the entire uterus. So people will tell you they're not painful. I thought they were painful. Now, once I had a true labor contraction, I realized why people said that, because they're very different. True labor contraction is a whole different ballgame. But, you know, they may be very uncomfortable for you. And if you're having a lot of them, rest is best. Rest, take a warm bath, take a warm shower, drink warm liquids, have your partner give you a massage. Things that induce relaxation are going to help reduce the amount of Braxton Hicks contractions. Braxton Hicks have a purpose, you know, that uterus is exercising, okay? Just like I asked you to do some exercise, your uterus is exercising and practicing and getting in shape for labor. Now, true labor contractions, the whole point of those is to change your cervix. So they do change your cervix. They do become longer and stronger. They do get closer together. You know, if they start out, they may be irregular at the beginning, but it's a train that once it starts moving, okay, it's just going to continue on. It's not something that rest is going to make stop. Okay, so true labor contractions is this train. We start out kind of slow, but as we get more and more power behind those, it's going to be just keep on moving. Okay, and those contractions that were irregular will become regular. So you can start timing them and seeing kind of what's going on there. I think I already mentioned you need to rest if you're having a lot of practice contractions. So let's talk about how to time contractions. This is showing the duration and frequency of contractions. When we talk about duration, it's from the beginning to the end of a single contraction. Okay. When we talk about frequency, we're talking about from the beginning of a contraction to the beginning of the next contraction, which people kind of find confusing. You usually think of, you know, you measure from the end of something to the beginning, but we're actually measuring beginning to beginning. And so you can see on this little example that the contractions are a minute long and they are 5 minutes apart. Okay. There's tons of apps out there that you can use to track contractions now. I did include a contraction timing chart in your handouts, so you can certainly do it like I did back in the day. Just mark it on your little piece of paper. But you know, whatever method you use is fine, whatever works best for you. If you're going to use the apps, there's lots of them. I would download a couple and kind of play with them and see what you like and what you don't. All right, so when I talk about your cervix, I'm talking about that little neck at the bottom of your uterus. So this little graphic kind of shows the anatomy of the uterus and shows you where that cervix is and where the vagina is in relationship. It's also showing the difference in cervical dilation and effacement. Okay, so number one down there, that cervix is completely intact. It's not effaced. It's not dilated. In fact, it still has the mucus plug in it. As labor continues, that baby's head is being pressed against that cervix with each contraction. And that is what encourages it to start effacing and then dilating. Okay. So the cervix in the second picture is about halfway effaced. Okay. Which means it's thinning out. And then the third picture, that cervix is completely effaced and we're starting to dilate. So we're dilated to about a 3 there. And then the final picture, we're complete. Okay, cervix is 100% effaced and we're dilated to 10 centimeters. So getting ready to start pushing here. We also, in addition to effacement and dilation, talk about pelvic station. Okay, and that is the relation of your baby's head to your pelvis. Okay, so it's pointing to the little ischial spines there on the back of mom's pelvis. And that is 0 station. Okay, so right now, baby's floating around in his or her water bed, just having a good old time in those minus stations, probably -4, -5. Now, as you get closer and closer to time of labor, baby's going to start dropping down into that pelvis, lower and lower. And then when you head into the hospital, you're probably going to be about 0 station. Okay. And then as you progress, you're going to head into the plus range, and then it's a boy, it's a girl. Some other signs, that dropping into the pelvis, that's lightning. That means that that baby is moved down. The reason they call it lightning is because this is the first time you can get a deep breath in months. You feel lighter because you can actually breathe, which you're going to need to use when you're in labor, be able to use that lung capacity. Bad news about lightning is the baby's further down in the pelvis, so you're probably going to have to go to the bathroom a little bit more often because they're putting more pressure on your bladder. Rupture membranes, like I said earlier, that's the deal breaker. If that happens, you're heading to the hospital right away. Okay. Amniotic sac is that protective barrier from the outside world. And once it's breached, we need to be monitoring you and the baby, make sure that everything's going okay, everybody's tolerating everything, we're not developing any kind of infection. So that one, we recommend you head on in. Sudden burst of energy, the nesting instinct can be pretty pronounced. It's overwhelming getting your home ready and padding that nest for the baby. It's really hard to overcome that instinct. You know, you feel like you need to re-roof the house and repaint everything and move the furniture, and you know, hubby's going to be tired because you're going to be telling him what to do. But you know, the best thing for you to do when you feel that urge is to rest, because it's going to happen soon. That's the whole point of the nesting instinct. Your body's telling you it's time, you need to get ready. But you know, labor's hard work, and if you can rest, it will help you to have enough strength whenever you are ready to actually go into labor. When I was pregnant with my second child, I was probably 38 weeks, and I had this overwhelming urge in the middle of the night to clean the kitchen cabinets. And I'm not just talking rearrange, I'm talking I pulled everything out and I scrubbed. And Aaron came in about 3 a.m. and wanted to know why this was happening. You know, I was pregnant with a 10-pound baby, so I was as wide as I was tall, and I was standing on the kitchen counters scrubbing the inside of the cabinet. I couldn't explain myself because, you know, obviously I wasn't going to put Asher in the kitchen cabinets. But anyway, he very gently reminded me I needed to rest and got me down off the counter and we went and laid down and went back to sleep. So, it can be quite silly and not make sense. So run it through the logic filter for one thing. But, partners, your job is to help mom be reminded to rest. Gently, don't make fun. It's hormones that are inspiring this. I hear a lot that women will say, I got food poisoning and I went into labor, or I got the stomach flu and I went into labor. But you actually have a big shift in your hormones right before you go into labor. And for whatever reason, our digestive system does not like that. And so we have a recurrence of the nausea, vomiting, sometimes diarrhea, sometimes indigestion that can, we're familiar with, especially early in pregnancy. It will happen with that shift in hormones right before labor. So it may not be that you got a bad burrito. It may be that you're actually having a shift in those hormones. And then I don't weigh every day. I never have weighed every day, but if you're one of the ladies that does that, you may notice a little drop in your weight prior to going into labor. So if this is your first baby, you're going to head to the hospital when your contractions are 5 minutes apart. They're lasting at least a minute, and that pattern's gone on for an hour or more. Okay. Some doctors prefer you wait till they're 4 minutes apart. So, you might have a conversation with your doctor about their preference. So it's the 4-1-1 or 5-1-1 rule. If this is not your first baby, then you're going to head in a little sooner. You're going to come when the contractions are 10 minutes apart, lasting a minute, and that's gone on for an hour. If you're a first timer and you live far away, you're going to head in for the 10-1-1 rule rather than the 5-1-1 rule. And then I've already mentioned, you head in whenever your bag of waters breaks. Does not matter what stage of labor you're in. And then, if you have abdominal pain that's not stopping, if you have bright red vaginal bleeding, if you're vomiting with each contraction, those are not normal. Like I mentioned earlier, you will have some bloody show, but if you're having frank, bright red vaginal bleeding, head on into the hospital. And then, of course, your doctor may have specific instructions for you. This is a birth plan. I should have included it in your handouts as well. This is just a sample for you to peruse and kind of get ideas from. I do believe in birth plans. It's a concise, simple way to communicate your preferences. As you are reading and coming to classes and learning about labor and delivery and postpartum, you should be kind of in your mind developing this toolbox, and you're putting in that imaginary toolbox all of the things that you want to utilize when you are in labor, when your baby is born, in case you have a C-section, all of those things. And the birth plan is a good way to write that down and share it with your doctor, with your partner, with people that are going to be your support system, with your nurses, okay, and other staff that's going to be taking care of you. I don't recommend a lengthy birth plan. I have seen them that were 30 pages. And ultimately, those are the moms that I think are probably most disappointed in their experience because they're trying to over control. Labor has a personality, and each one is different, and it's going to have its own path that it takes. Of course, we can use our tools in our toolbox to cope with labor, to be able to help labor along, but you're not going to be able to control it step by step, okay, because it has its own life. But you are going to be able to have in that toolbox ways of coping with contractions, ways of feeling more comfortable, ways of, how you want your baby to be cared for. So this is just a sample. You can certainly use it. You're welcome to do that. But you can also find your own, just simple, concise, short, sweet, and to the point preferences for your birth. But also keep in mind that it does have its own journey that it's going to take. It may not be exactly what you expect. So stages of labor, it comes in 4 stages, and we're going to talk about all 4 of those here in just a second. First stage of labor has 3 parts. This is the what we think of as labor, okay, going from 0 centimeters to 10 centimeters dilated. getting ready to start that pushing stage, which is our second stage. I want to encourage you during early labor, the first portion, to stay home as long as you possibly can. Early labor is where your hormones are kind of amping up and getting ready and making that train start driving. And as early labor continues, more and more of those hormones are getting into your system, and it actually helps to amp up that labor, get those contractions regular. The longer you can stay home in your safe environment where you feel loved, you feel warm, you feel comfortable, you can snuggle with your partner and snuggle with your puppy or kitten. You can watch your favorite TV shows on Netflix. You can do whatever makes you happiest. You're going to actually produce those labor hormones better, okay? Oxytocin is the hormone that drives our labor. It causes our contractions. And it's also our love and bonding hormone. And so the more safe and loved and comfortable you feel, the easier it is for your body to produce that hormone. So if you can stay home in early labor, for one thing, it's the longest stage part of this stage, and it will help you to be able to feel in control. It's also, you know, we're very clinical in the hospital, even though we try to make it as homey as possible. You know, we're going to tell you have to pee in a cup. We're going to put you in a gown. We're going to give you ice chips rather than food and drink. So if you can stay home, statistically, labor is shorter, and also there's less chance of needing medical intervention, if that makes sense. So, you know, I'm not going to come take your sandwich away either, which I do encourage you early in labor to be sipping on fluids to stay hydrated, and you can also eat light snacks to keep your energy up. So I'm going to get to the question about the episiotomy here in just a little bit. Early labor is on average 6 to 12 hours for first-time moms, but it can last a day or more. Okay, so if your mama told you she was in labor for 5 days and, you know, made you feel guilty your whole life, she was in early labor for most of that. All right. It is the stage where you start out irregular with those contractions, but as it progresses, we're becoming regular. So maybe 30 minutes apart to begin with, and then by the end of that course of early labor, you're at that 5-1-1 that we mentioned earlier. Contractions are short in early labor. They're 30 seconds to 45 seconds long, very manageable. You know, usually you have a great big burst of energy when you realize you're in labor. And so you kind of like are running around the house, you're excited, you're making sure your bags are packed, you're wanting to call your mom and all your friends. And, you know, the best thing to do is to rest. Usually labor starts at night. And if you can get back in bed and just snooze between contractions, you may not be able to sleep through a contraction, but you can rest between them, you know, because you start out, they're 30 minutes apart. You can have a contraction, sleep for 29 minutes, and then you may have, you know, your second contraction. They're not, I think people kind of think, okay, I'm going to go into labor and I'm going to be in constant pain. And that's not how labor works. You get breaks. So absolutely rest between those contractions if you can. And then next morning, you can get up and call all your buddies, okay, and your mommy. Most of the time, we do not see breaking of water during early labor. Now, about 10% of women, that does happen, or it happens prior to labor starting. If that's the case, then go ahead and head to the hospital. Otherwise, stay home, okay? You will see bloody show as that cervix is opening up, and it will continue to get a little bit more and a little bit more as you progress. But it shouldn't be, you know, copious amounts of frank bright red bleeding. Active labor, this is a shorter phase of labor, but this one is, you're going to see partners, especially, you'll notice a change in attitude in mom, okay? We joked around, we kind of skipped around and were excited and, you know, not really having to stop. You know, you'd have a contraction to be like, oh, tee-hee, I'm having a contraction during the early labor. During active labor, this is kind of where the rubber meets the road, okay? And those contractions are regular now. They're more intense. They're lasting longer. They're 45 seconds to a minute. And you will see an attitude change in mom. She's much more focused in on what's going on in her body. She's having to stop and breathe through those contractions. That's where you may have to bring some more of those tools out of your toolbox and use them to cope with the contraction pain, okay? This is where you have another shift in hormones as well, and so your friend nausea and vomiting may show up a little bit, okay? We want you to start heading into the hospital when you hit this phase. It's on average 1 to 4 hours for first months. Transition, this one is the most intense portion of labor. Like, this is, contractions are one right on top of the other. The contractions may be having 2 or more peaks. They're lasting 1.5 minutes. So, you know, they're 1 minute to 3 minutes apart, very strong. They may, you know, you feel that contraction, it goes up to its peak. They may give you a little bit of a break and then peak again, and then it'll come back down. It may do that more than twice. This is your body's final push to get you dilated. Okay, so during early labor, we're dilating from 0 to 6 centimeters. Active labor, we're dilating from 6 to 8 centimeters. And then during transition, this is your body's final push to get that cervix completely dilated, so 8 to 10 centimeters in this stage. You have a lot of stimulation going on in your body at this point, and you are going to need a lot of support. So partners, you know, if you're the kind of partner that thinks, oh gosh, I don't really have a role, I don't know what I'm supposed to do, your role is to be there right by her side, encouraging her, lavishing words of affirmation and encouragement on her, helping her to remember to relax between contractions as much as possible, helping her to breathe. If she has a little panic attack during this, because this is such an intense portion of labor, partners, you're going to help her to be able to focus in on you and say, okay, I know that this is tough, but you're doing a great job. Why don't you breathe with me? Okay. The good news about transition is it's relatively short. 30 minutes to 2 hours for first-time moms, okay? So it's intense, but it's nowhere near as long as the rest of the labor process was prior to this, okay? Because of the intense stimulation in your body, you may experience trembling, okay? And it can be quite pronounced. It's pretty intense shaking. You may have hot flashes, sweating. You may have chills. You may feel intense rectal pressure, okay? The danger in transition is that you will feel the urge to push and start pushing before your body's really ready. So you want to be communicating with your labor and delivery nurse and making sure that you don't start pushing before that cervix is out of the way, okay? If you push before the cervix is moved out of the way, then it could cause swelling in the cervix, which may set you back, and it can cause tearing in the cervix, which is definitely not something that we want. So be talking to your nurse if you feel the urge to push. Make sure that you're really ready before you start, okay? Nausea and vomiting can show up again in this stage. It's another release of hormones and, you know, just so much stimulation in your body that you may see that nausea and vomiting show up again. So I've talked about membrane rupture. This little graphic is just showing what to expect. If you have a high break in that amniotic sac, it may be just a little trickle of fluid, okay? And then you're going to have leakage as the baby moves and you move. With a low break in that amniotic sac, it's that gush of fluid like we think of. Doesn't matter. Wherever it breaks is fine. You may feel a pop. You may not feel anything except for the gush of fluid. Just note, I think my next slide talks about, note the color of the amniotic fluid. We usually expect a clear pinkish fluid, but if it's green or brown, your healthcare providers need to know. If it has an odor, we need to know if there's a lot or a little, and what time did it break, okay? Because that's when that protective barrier is breached, so we want to be monitoring and keeping in mind that time, okay? So remember the acronym COAT for color, odor, amount, and time. And then I want to mention about artificial rupture of membranes. This is showing you do sterile vaginal exam. This is done by your physician, and they use an amni hook, which is a one-time use little plastic. It looks like I think it's crochet hook. And sometimes there's a cushion of fluid between the cervix and the baby's head. That baby's head putting pressure on the cervix is what causes it to dilate. Sometimes if that cushion of fluid is in the way, you'll kind of peter out on your progress in changing that cervix, and the doctor may offer this as a way to augment your labor by just breaking your amniotic sac. So sterile vaginal exam, they find the edge of that bag, they prick it with the amni hook, and that removes that cushion of fluid, puts the baby's head down on the cervix, and hopefully will help to get that labor progressing again like we want it to be. Okay. Second stage is the pushing stage and the actual birth of the baby. Okay. So once you get through the intensity of transition, you may not feel the urge to push right away, or you may feel the urge to push before you get through transition. Everybody's a little bit different. Some women kind of get a breather and your body just wants a break. And so you kind of have this few moments where you can rest. Okay. And it's best if you are one of those women to allow it to be your body's idea to start the pushing phase. You know, if you've got an epidural, you may not be able to tell. You may have to have some coaching from your labor staff to realize when it's time to start pushing, because you may not be able to feel anything that feels like the urge to push if you've got an epidural. But if you're doing it au naturel, okay, then you may think, oh gosh, there's something wrong because I don't feel the urge to push and I'm through transition. It's just kind of a little gift that your body gives you. Okay. And so if you get that gift, take advantage of it and wait until it's your body's idea to start pushing. We'll talk a little more about pushing when we get to the comfort measures stage of this presentation, but just a few guidelines here. If you can relax your face and your jaw, it may help you to be able to push more effectively. And I know that that sounds really weird because it's the wrong end, but if you're clenching your jaw and you're clenching your face really tight, most of the time you're also clenching that pelvic floor. And it's very hard to push a baby down through a pelvic floor that is tight. Okay, so we want to relax that pelvic floor as much as we possibly can. So making sure that your face is not tight may also help ensure that your bottom is not tight. When you push, you're going to take a big deep breath and you're going to put all of your effort pushing from your diaphragm muscle down to your bottom. Okay, and it sounds really gross to describe it this way, but the best way I know to describe it is you're pushing into your bottom like you're having the biggest bowel movement ever. Okay, it's not exactly the same spot, but it's very close to the same spot. And if you can kind of focus and put that effort into that area, you're going to be able to more effectively push. I've had moms who thought, okay, I'm just going to, like crunch this baby out. But you do tighten those abdominal muscles, but you're not going to crunch the baby out. You're actually going to put all of your effort into pushing into your bottom. We want to try to get 3 to 4 pushes in per contraction. Most women can comfortably hold their breath for about 5 to 6 seconds. So you do not have to hold for a count of 10. We used to make moms do that, and basically by the end of a count of 10, moms are dizzy, their mouth is tingly because they're not getting enough oxygen. If your body's telling you you need oxygen and your baby needs oxygen. Take a breath. Okay, so you'll take a big deep breath. You're going to hold it, put your chin down to your chest, you're going to push into your bottom. Then 5 to 6 seconds later, when you feel like you need another breath, you're going to take another breath. You're going to do the same thing. You're going to get 3 to 4 pushes in per contraction. Sometimes your doctor or nurse will kind of help give you some guidance, especially if you're not pushing effectively. They can use a gloved finger to show you where to put that energy. They may kind of give you some directions to help you be more effective in your pushing. So, make sure that you are not offended by that guidance, that, that they're helping you out. They can also bring a mirror in, which when I teach on-site classes, everybody looks at me like I'm crazy. But a mirror can be a really useful tool to know where you're putting that energy, and you can actually see where you're pushing. So it can make your pushes more effective. A lot of women also just want to see the birth of the baby's head. So, you can bring the mirror in for that as well. Okay. Pushing positions, we think of lying on our back in the lithotomy position with our legs up as being the only option, but actually you can push in any position that you can get into. Now, if you've got an epidural, you're very limited as to what you can do, but you can turn side to side, and I encourage you to do that. And your partner can help you get your legs up so that you can get into a better pushing position. But if you lay flat of your back for your entire pushing stage, it's going to make it longer and it's going to make it more painful. So utilize all different kinds of pushing positions if you can. You're going to push mostly with your nurse. That's another thing I think people have a misconception about is, your doctor's coming in at the end to push with you and deliver the baby. But your pushing stage for first-time moms can be up to 3 hours. I'm not promising that that's going to happen to you. It can be 2 pushes too. But the pushing stage is going to be a process, and you're going to go through that with your nurse. And you can certainly change positions every 30 minutes to an hour, even if it's just turning side to side. And it will help you to have a shorter pushing stage and help you feel better about your pushing stage as well. Lying flat of your back kind of tilts your pelvis upward, and you're kind of pushing uphill if you're lying flat of your back for your pushing stage. Now, you can get on your back for rest if you need to, but don't use that as your sole position. And this is just showing different pushing positions, the semi-sitting, which that first one, the semi-sitting, you might be able to get into with help with an epidural, using the bed, and the bottom of the bed is down on that picture where she's got her feet, but the head of the bed's all the way up. She's got partners on both sides helping and holding her legs. You might be able to do that one during an epidural, but you will have to have help for that. But if you don't have an epidural, the sky's the limit. You can do kneeling, you can do hands and knees, you can do squatting. And then that bottom one on the right is showing the side lying position that I was talking about. Mom's got one leg, partner's got the other, and she's pushing on her side. So I've mentioned you guys are so important, you support partners. Mom just needs you to be there more than anything, but you can help in a variety of different ways, helping her to reposition herself. If she needs somebody that counts during contractions, it's could be helpful. If she doesn't like counting during contractions, you can discourage other people from doing it. But reminding her to rest. If you're allowed down south, and you see the baby's head crowning and you see all this hair or whatever, you can tell mom about it so that she feels encouraged. She feels like she's making progress. Epidural, the question is, so if an epidural limits mobility, can it slow down the process? It can, although the studies differ on whether it does or it doesn't. And I think it really is dependent on mom. If you get an epidural and you lay flat of your back or you lay in one position for your entire process, it's probably going to slow down your labor. If you are one of those women that is just so tense because of the pain and, fear or whatever, and then you get an epidural and it helps you to relax, then it may actually speed up your progress. So it's hard to say. The studies differ as to whether it speeds it up or slows it down. I think it solely depends on your labor process and how you are coping with everything. And, you'll read a lot of stuff out there about anti-epidural. You'll read a lot of stuff, and probably talk to friends and family members that are pro-epidural. I'm pro what works for you, okay? Just keep in mind that you still have control when you have an epidural, and it is okay, and you should at least change position side to side every 30 minutes to an hour. Third stage is delivery of the placenta. We deliver baby, we put them on mom's chest, we dry them off, we're assessing them, you're counting fingers and toes, you're doing your skin-to-skin time with that baby and getting to know them. And about 5 to 20 minutes after the delivery, you'll feel some smaller contractions. That's signaling it's time for the placenta to be delivered. And your doctor will deliver the placenta. They're going to check it out, make sure it's intact, make sure there's not anything that needs to be addressed. And then they're going to get you cleaned up if you have a tear and P's, they're going to sew you up. And then, excuse me, you're going to go into your 4th stage, which is your immediate postpartum adjustment and your bonding time with your baby. All right, so we're going to head into the more natural ways of coping with contractions and ways that you can actually help your labor along. This is the portion of class that I usually have the hands-on labor stations. So pull up those labor station cards after we're done and look through those, and I encourage you to use them to practice with, especially if you're planning natural labor. This class in no way is a full preparation for natural labor. If you're planning natural labor, I encourage you to continue reading on. Lamaze.org is an excellent website for information on natural birth. I can't remember if I sent you guys out the Mother's Advocate pamphlet. I will look, and if I didn't send it, I'll send it out to you. But it's got good information on coping naturally. But yeah, this is like the intro to natural birth. It is not the everything you need to know about natural birth. First thing I want to talk about though is fear, because fear will negatively impact your labor. Okay, when we're afraid, we produce a lot of catecholamines, which are our stress hormones. Stress hormones counteract the effects of our oxytocin. Okay, and so it can slow down your labor just from you being afraid. Okay, and the best way to cope with those fears is to deal with them now and work on them now. Labor is as much a physical process as it is also very mental. And if you can get your head around it, then you've already won. Okay, so I've had women tell me, you know, I don't want to know anything because it's just going to make me more afraid. But actually, the unknown is way more fear-inducing than having knowledge. So if you're afraid, read, talk to your doctor, talk to me. I'll be happy to answer questions. You know, talk to friends that have had positive birthing experiences. Don't believe Dr. Google about everything, okay? Evidence-based, research-based information is the best thing to base your decisions on and to get your information from. Lamaze.org is evidence-based, research-based, by the way, so you know you can certainly look there. But there are countless numbers of books. I sent out a resource list, and it has lots of books and websites on it, so I encourage you to look through those. Let's talk a little bit about some common fears. Hopefully we can break those down. Grab my list. There we go. So some common fears. Pain. I'm afraid I'm not going to be able to handle the pain. That's probably, if I were to pick the number one, that's the one I hear the most. But if we can reframe the way that we think about pain and labor, it may help you. Pain in labor is different than any other pain that you're going to feel in life. Okay, if you break your arm, your body is telling you there's something wrong and that you need help. Okay, that pain is not going to go away without some kind of intervention. Okay, whereas pain of labor, contraction pain, is telling you there's something right. It's telling you it's time. It's telling you, hey, we're fixing to meet this new person that you've created. And so if you can kind of reframe it in the, okay, this pain is telling me that there's something right, okay, rather than the way we think of pain as, oh my gosh, this is suffering, okay, because it's not the same in labor. So if you can just change your thinking, it will help you. And then also, you can cope with pain. You can do things. You don't just have to lay there and be in pain. You know, and you can change positions every 30 minutes to an hour. You can make sure that your bladder is emptied. You can make sure that we've dealt with those fears that you have been having brew in the back of your brain. We don't want you to feel powerless. Okay, so that toolbox that I talked about, that's your friend, because those are the things that are going to give you power. Okay. Not making it to the hospital on time is one that we usually go around class and I ask everybody what their fears are. And I hear that one from dads more than moms. But In the US, okay, this information is from Lamaze. First-time moms, average labor is 20 hours. Okay, so you have a really great chance. There's a huge time frame there to get to the hospital on time. And then, the statistics are 0.4% of babies are born before arrival to the hospital. So you got a 99.6% chance of getting there on time. It's pretty good odds. I don't want to have an episiotomy, or I don't want to tear. Okay, so when we talk about an episiotomy or tearing, we're talking about your perineum. Okay, so the piece of skin between your vaginal opening and your anus. Okay. The good news about episiotomy, okay, where they actually cut, is that we don't routinely do that anymore. Okay, they do offer it, if there are certain cases where it is applicable. But when I first started in nursing 23 years ago, every patient I took care of had an episiotomy. Okay, I do not see that anymore, and I'm thankful for that, because studies have proven that women heal better from a superficial tear rather than an episiotomy. So with a first or second degree tear, which is what we expect from, a labor, you're going to heal relatively quickly. It's superficial tissue, it's the skin. It doesn't get into the deeper structures, and super simple to heal from. Okay, so most of the time, that's what we're seeing, is those superficial tears. Now, with an episiotomy, so your doctor should talk to you before performing one and get your permission, number one. But if it's deemed necessary, an episiotomy goes deeper in, and it is harder to heal from. It's not that you won't heal, it's just going to take longer. You're probably going to be more sore. Episiotomy increases risk of a deeper tear as well. And we can have a third or fourth degree tear, although those are pretty uncommon. I mean, I see them, but we do about 230 deliveries a month. When I look at the stats, we usually see 3 or 4 third or fourth degree tears, so not very common. Episiotomy will increase the risk of those, though. There are things that you can do ahead of time, allowing yourself to go into labor on your own, not having a lot of medical interventions. There's a stretching exercise I'll show you here in a little while. I have a little graphic that shows a perineum, and we'll talk about a stretching exercise you can do to help make your perineum more stretchy, which will reduce incidence of tearing. So in the US, my statistics for third or fourth degree tear is 0.25%, so very low. And then episiotomies, we just don't routinely do them anymore. So hopefully that's comforting to you. And then afraid of a C-section. About a third of our deliveries in the US are C-section. You can do things to help reduce your risk. Going into labor on your own is one, getting extra rest close to your due date, staying home as long as you possibly can, because of the reasons I mentioned earlier, of helping your body get that labor process going. But also, the longer you're at home, the less medical interventions are likely. Medical intervention begets medical intervention begets medical intervention. So that kind of puts you on the road to C-section. Certainly not a guarantee. We do successful inductions all the time without C-sections, but it puts you in a higher risk category. Having support in labor reduces chances of C-section. Eating healthy, exercising prior to your delivery will help reduce C-section rate. So, you do have some power there. And then another one that I hear pretty frequently is, moms usually say, I'm afraid something's going to happen to the baby. I'm afraid the baby's going to die. And in the US, it is a 0.004% chance of the baby dying. And then dads usually tell me, I'm afraid something's going to happen to my wife or my partner. In the US, that's a much less chance even than the baby. It's 0.00028%. So very low chances that something's going to happen to the baby or to the mommy. All right, so this is the fear, tension, pain cycle. And this idea came out in the 40s and 50s. And the thought is, fear increases tension. Tension increases pain. Pain increases fear. Okay, and it's just kind of this downward spiral. You can enter the cycle anywhere in here. You know, if you get tense, then you feel more pain, and then you start feeling fearful. The idea, though, is that we want to break the cycle in every way that we possibly can. Okay. Fear, tension, and pain will adversely affect your labor. It's going to make it longer, more painful, and slower, or well, not slower, but it's going to adversely affect it. You release all those stress hormones, it affects your labor. It also can affect the baby as well, because they get a dose of those stress hormones also. So we want to break this cycle. So to break this cycle, we're going to increase our knowledge to reduce our fear. Okay, so you're taking classes, we're reading, we're researching, we're talking to people about positive birth stories. Do not listen to negative birth stories. Okay, everybody in the world sees a pregnant baby or pregnant mommy and wants to tell you some horrifying tale about labor, and do not listen to them. Most of those stories are not true, or if there's some truth in there, they're highly embellished. Don't listen to that stuff. Tell them that Amber told them to stop. Okay. You want to build up your confidence now. So that's what that reading is going to do for you. It's going to give you power. And those people trying to tear you down and tell you you can't do this, tell them to talk to the hand or whatever. Partners, that's another way that you can be supportive, is to stop, you know, your cousin from telling you that her best friend's brother's wife had this horrible experience. It's probably not completely true, and you know, it's just not necessary. Relaxation techniques, breathing techniques, having control of your environment reduces your tension level. And then positioning, like I've mentioned, and other pain coping techniques can help reduce your pain. So speaking of breathing, breathing and breath control are important in labor. If you came today hoping to learn the hee-hee-hoo-hoo breathing of the past, I'm not going to teach that to you. Lamaze actually were the ones that came up with the hee-hee-hoo-hoo breathing, and they, in their wisdom and through research, discovered that all that patterned memorization did not help moms. Now, their research does show that breathing awareness and conscious breathing, you know, being aware of what you're doing, helps, but you don't have to do hee-hee-hoo-hoo breathing in early labor and hoo-hoo hee-hee breathing in active labor. And, you know, they had all these patterns you had to memorize for the different stages. Mostly moms just ended up confused and dizzy because they couldn't remember what they needed to do. So conscious breathing and breath awareness, that means you are purposefully, voluntarily controlling your breathing. It's a comfortable pace for you. It is what your body is telling you you need. Okay. You can practice cleansing breaths in life every day. Cleansing breaths are a great way in labor to begin a contraction. You take a slow, deep breath in, you hold it, and then you control it as you exhale. And it's really useful to get on top of a contraction. So you can do a cleansing breath at the beginning, and then most women like slow, deep breathing to control a contraction. And then at the end of the contraction, as a cleansing breath can also help blow off that contraction and get it away from you. Okay. So we also do cleansing breaths for my whole family has anxiety issues. And so we do slow cleansing breaths to help get on top of an anxiety attack. And we do slow, deep breathing to help get through that anxiety attack. So cleansing breaths can be really useful throughout life, not just in labor, but I'm gonna switch over, and I want you guys to kind of get comfy where you are and settle back in your chair or snuggle with your partner or whatever it is that you want to do. And I'm going to kind of scooch back in my chair. And I want you to practice a cleansing breath. Okay. And you can use visualization if you want, having a picture to focus on or just a place in your mind to focus on also is a great technique to help with relaxation, with gaining control and distraction from a contraction. So, you know, if you want to practice that now, that's fine. But I'm going to do one, and then I want you guys to do a couple with me just so you kind of get the hang of it. Most people are comfortable breathing in over 4 to 5 seconds, holding the breath for 4 to 5 seconds, and then breathing out over 4 to 5 seconds. Okay, so I'm going to close my eyes, kind of get back in my chair, and I'm going to start doing a couple of cleansing breaths, and you guys can join in with me. Okay, and as I breathe out, I'm just going to allow my shoulders to relax and kind of just let everything fall down and relax. Okay, so in and hold it, and then out. And in and hold it, and out. One more, in and hold it, out. Okay, so if you did a couple of those with me, hopefully you can kind of feel that relaxation. My shoulders feel much less tense now. And if you utilize that in labor, you can get on top of those contractions a lot easier. Most women feel most comfortable doing slow, deep breathing to deal with a contraction. So what I would suggest is trying cleansing breath, and then slow, deep breathing. And a cleansing breath. Okay. But your body will take the lead as to what works best for your particular point in transition, your particular point in active labor. You may have the urge to use some of these other breathing techniques. Quick deep breathing can get you into trouble. That's the only one that I want to caution you about. If you do a lot of that, that's hyperventilation. So you may get tingly and dizzy. But a few quick deep breaths may be a way that you need to deal with that contraction. So you may cleansing breath, a couple slow deep breaths. No, that's not working for me. Some quick deep breath, and then go back to your slow deep breaths. Use your cleansing breath to blow it off. I do want to mention the breathing with moaning because it is normal to do that in labor. A lot of people are afraid of making a spectacle of themselves when they're in labor, but moaning is just kind of this primal way of expressing yourself. I've had moms tell me that, that was the go-to for them to deal with a contraction. For whatever reason, it comforted them. And who knows why? Maybe you feel like your inner cave woman is communicating your needs or something. I don't know. But I do know that moaning, not high-pitched squeal or scream, but moaning, using those lower tones and relaxing all of this in your neck, your larynx and all of the muscles in your neck and your jaw, that will help to relax your bottom. So that may also be why we feel that urge to moan when we're in labor. And I'll do one here so you guys can kind of hear it. I usually make people practice it in class, but I won't make you guys do it since we're online. But you breathe in, and then as you breathe out, you just allow that moan. Or whatever it is that feels comforting to you. It's absolutely okay. Now, if you think you're going to be a moaner, warn your coaching partners so that they don't think that just means that you're suffering terribly. Just help them to know that it's a coping technique. Okay. Are we currently required to wear a mask during labor and delivery per COVID policies? Yes, everybody is required to wear a mask. We'll provide the patient with a mask, but partners have to bring their own, and they have changed the policy to if you don't have your mask with you, they will send you away. So make sure that you stick a mask in your car. But yeah, currently the patients and anybody visiting have to wear at least a fabric mask. I've mentioned this already. Lavish these ladies with words of affirmation. Okay, super important to tell them what a great job they're doing. Okay, help them to feel loved. You know, there are examples on the screen of things you can say, but use your own love language with each other. It does not have to be, you're a strong, amazing woman. If that's not something you'd say in normal life, she's probably going to think that you're crazy, you've lost your mind. In my video I used to show in class, the dad says, if anybody can do it, you can do it, sweet pea. And everybody laughs because it seems so silly to us. But you know, if that's the way that he talks to her in normal everyday life, then hey, that's great. He's doing his job. So make sure that you're lavishing them with words of encouragement and telling them how beautiful they are, how great of a job they're doing, how much you love them. Okay, super important. The more supported women feel in labor, the better they will feel about their labor experience. That's actually been studied and shown to be true. They've also studied how women feel about their relationships after labor, and if they did not feel supported during labor, they report on their relationship more negatively. So just being there and being supportive and helping her through this process is going to improve your relationship. So it's important that you're there. Progressive relaxation is a technique you can use to learn how to relax. This is not something you're going to do in labor, but it is something that you can start practicing now in order to teach your body and your brain how to relax when you need to. You can Google progressive relaxation script, and there are bunches of them out there. Some of them are very regimented. Some of them are more kind of like, you know, touchy-feely, hippy-dippy, which is what I prefer. When we do a progressive relaxation script in class, which I'm not going to do with you because there's just really not enough time today. But when I do one in class, I put on soft music. I turn the lights down low. I have everybody kind of relax in their chair. And then I read the script to them. And you're using your cleansing breaths. Okay, so you do a cleansing breath. As you're taking in the air, you're tightening a muscle group in your body. And then as you relax that, or as you breathe out, you're going to relax that muscle group. Okay, and you start at the top of your head and you work your way down to all the way to your toes. And by the time you're done, the goal is you have completely relaxed. This is something that we also do for anxiety at my house as well. It has an added benefit of training your brain to listen to your partner. If you have your partner read you the script and you are kind of honing in on their voice and listening to them as they're asking you to relax, when you're in labor, you will have kind of trained your brain to listen to them when they ask you to relax, and it will come more readily because you've done this work to be able to respond to their voice. A great thing to do is at nighttime when you get into bed, get all snuggled up, and partner, you read the progressive relaxation script as she does it. And, you know, I love progressive relaxation. It is just a really wonderful way to get rid of the tension of the day. So even if you don't use it for labor, use it as a way to help yourself to go to sleep, because it does work. I attest to that personally. So relaxation basically just makes labor better, and it helps you to conserve your energy. It will reduce your sensation of pain if you can relax your muscles. The same stimulus when you're relaxed does not feel near as painful as when you are tense. So learning to relax will benefit you tremendously. Positioning, I've mentioned this. I think I harp on this a lot because I feel very passionately about it, but changing positions every 30 minutes to an hour when you feel out of control, when you feel like you are in a lot of pain, when you're not making progress. changing position can make all the difference. You know, if you're at a 6 and you haven't been making any changes and you get up and you go sit on the toilet backwards in a squat, it will probably progress your labor. So just that simple intervention of changing position can make a huge difference. So make sure that you are changing your position. It helps to move that pelvis. I'm going to show you guys my pelvis real quick. Hang on. Well, not my pelvis, but you know, my sample pelvis. Okay. So this is approximation of a female pelvis, okay? And it's flexy, all right? So when you do something like a squat, okay, we're opening that pelvic outlet, okay? You can see the difference, all right? When you are, say you're laying on your side and you get this top leg up, you're asymmetrically opening that pelvis, which helps that baby to rotate and move down, okay? So when you head into the hospital, baby is going to be engaged in the pelvis, okay? But when you open up that pelvis, it helps them to do that internal rotation, because right now we're in our water bed. The more you're opening up that pelvis, the more easily that baby can get that internal rotation and get into the position for labor, okay? Hopefully that helps it to make more sense, okay? But positioning just makes a huge difference, okay? In upright positions, you're also utilizing gravity, pulling that baby's head down onto your cervix to help progress your labor. So early, you know, it's easier early on to do the upright positions, but you can do them throughout your entire labor process, even while you're pushing, if you don't have an epidural. So utilize all of those positions, you know, whatever's comfortable and feels good to you in labor. You know, and it's a good idea to put a lot of ideas in that toolbox, because what you think will work for you now may not work for you in labor. So you may want to go to something else. Okay. So make sure that you're changing positions. I can't say that enough. Positions in labor include all different kinds. So this is just a listing of upright, kneeling, sitting, and lying down positions that you can utilize. And then the labor stations will help you to kind of understand those a little bit better, those labor station cards that I sent out. Massage is really helpful. It induces relaxation. It's a great distraction technique. You know, if you're not accustomed to doing a lot of massage now, partners, go ahead and start practicing. It will help her to feel better anyway. Pregnancy is rough, so massage is usually pretty welcome. When you're in labor, massage needs to be the stronger strokes, the more kneading, deep movements instead of tickly. If you're tickly massage, usually mom's so overstimulated by everything going on in her body, tickly massage is not welcome, okay? So kneading, crisscross across the back where you're using the heels of your hands across is helpful. Whatever feels good to her, okay? She's the boss when it comes to massage, but it can be a really useful technique. Sacral counterpressure and double hip squeeze. I'm going to switch back over. I forgot this was coming up. Oops. I'm going to show you on the pelvis. Okay. So when I talk about double hip squeeze, okay, this is front of mom. This is top of mom, bottom of mom. Okay, double hip squeeze is something partners can do to help mom when she's in labor. It helps to externally open the pelvis, which is freaky and weird. I didn't know this until I became a childbirth educator. I wish I'd known it sooner. But it can be amazing. Some women love it and think that it's very helpful. Now, if you're practicing this at home prior to labor, it may not feel great. So just be very gentle. The goal is to find the landmarks so that you're able to do it. And then you can try it in labor. And if you love it, then do it. And if you hate it, then don't do it. Okay. But the way that you find the area to do double hip squeeze is you find mom's waist. Okay. So up here's her waist. You feel down until you find the iliac crest. You can usually feel that externally. Okay. I'm pretty fluffy and you can still feel it on me. Okay. So you find the ridges of the iliac crest, and just underneath that, you will feel a little indentation. It's like it was meant for your heel of your hand, okay? It's on her side, it's not on her back. So we're on the sides of mom here. We are pointing our fingers up so we're not digging them into mom, okay? So pointing fingers up, got our heels of our hands in those little indentations under the iliac crest. And then you're very gently going to push in and up. Okay, and you can see my pelvis open up when I do that. All right. Now you will do this at the beginning of the contraction, and you hold it through the contraction. And then when the contraction is through, you very gently release. Okay, you don't want to just spring off because it will hurt her. But this will help to progress that internal rotation and the engagement of that head in the pelvis. A lot of times for laboring moms, because you've got all that good relaxed and flowing, it feels really good, okay, and it helps. But like I said, for practice, you're just finding the right place, okay? You're not actually going to just go full force in because it may not feel good right now. All right, and there is one of those practice cards is about double hip squeeze. All right, so for sacral counter pressure, okay, this is the back of mom. All right, so you can see her sacrum here. This little bony prominence is a mark where we will find this magic spot that you can rub, okay, and put pressure, and it will actually help her to relieve her pain. It's an amazing little spot on your back. I actually haven't been pregnant in 13, 14, almost 14 years. And when I'm having a bad back day, if Erin will put pressure right here, or even do, you can catch your hand kind of on that little bony prominence and pull down towards my bottom, it makes a difference in how I feel about my day. Okay, it relieves a lot of back pain. But right above that little bony prominence is this kind of flat spot. And if you rub that area, it releases our natural painkillers. It releases endorphins. And so that is a simple way that you can help relieve her pain just by doing massage in the right spot. Okay. The best way to find this is, okay, here's mom's back. Okay, so she's in hands and knees or laying on her side. You line up your middle finger. You've got your hand flat of her back. Your middle finger's on her spine, and you line it up with her gluteal fold, which is also known as her butt crack. And you're going to feel down until you find this little flat spot, and you find it and put your heel of your hand on it. A lot of times you can kind of feel that little bony prominence as well. You can push down towards her belly button. You can put your elbow in there and just put pressure. You can put a tennis ball there and rub it around, or you can just use the heel of your hand and rub back and forth across that spot. You can put your hand and catch that little bony prominence and pull down towards her bottom. All of that will help induce relaxation and pain relief. So best way to do that is hands and knees, or you can do it with her lying semi-prone. You can get to it easier that way. But, you know, if you are in doubt, you don't know what else to do, find that spot and just massage. Okay, but you can take a tennis ball with you. You can use one of those little massage doohickeys, or just your hands. Cold Coke can feel pretty amazing there, just rolling it back and forth. So whatever works for mom. Mom, you are the guide. You tell everybody what you need. Hydrotherapy can be really helpful. So getting in the shower and allowing warm water to run in the right spot. We have handheld shower heads in our showers at the hospital, so you can get in there and do that either on your low back or over your belly, whatever feels good. It'll help induce relaxation. We don't have tubs at the hospital, but if you're at home still and you want to get in the tub in a warm bath, that will help you to relax as well. Hot and cold packs can be really helpful too, especially in that sacral counter pressure spot. We have ice packs at the hospital. We don't have hot packs. So if you've got one of those little rice socks or, you know, little bean bags that you can put in the microwave, bring that with you and you can use it when you're in labor. Music can be a wonderful distraction. It does not have to be spa music. It can be whatever you enjoy listening to. So, you know, if you're into 70s glam rock or, you know, gangster rap or whatever, if that's going to get your juices flowing, get that oxytocin going because it makes you feel happy, then use that. Okay, it does not have to be spa music. Now, spa music can be wonderful too if that's your thing. And then aromatherapy can be helpful. I do warn against putting a lot of essential oils on your skin to start. I would do like a diffuser with them at first until you know how you're going to react to it. Because when you're in labor, you're so overstimulated, your senses are heightened. And if you put a bunch of essential oil on your skin and you don't like that smell that day, it's hard to get it off. So, try a diffuser with some essential oils if you're wanting to do aromatherapy. And then, okay, I promised we'd talk a little more about pushing. Pushing has this kind of rush. Usually you get excited, you kind of get your second wind, you've gone through the really intense transition, and then you get to this stage and you kind of have this energy, and that's a gift. It sounds silly to say this is the fun part, but you actually get to put some power behind those contractions, and you are going to get to see this baby. So you do get excited. You feel relief sometimes. This is just some pictures showing different positioning. If my thing will advance, there it goes. So this is a side lying position with partner holding the leg up. Of course, the one picture is they're just practicing. This is mama in hands and knees. She's on the bed. She probably needs more pillows underneath her, though. I wish they had more pillows. Or you can use a birthing ball, too. She could wrap her arms around the birthing ball and lean into it. Semi-sitting, we already talked a little bit about that one. Squatting, using the squat bar or not. We do have a squat bar at Middle Memorial. So utilize different pushing positions. And I've talked about the spontaneous pushing when it's your body's idea. So I'm not going to go through that again. But let me know if you have questions. Now, when you're pushing, okay, your doctor's going to come in and push with you at the end and deliver your baby. Now, part of the doctor's job is to reduce that skin of the perineum around the baby's head and to control the delivery of the baby's head, so that you have minimal amounts of damage to your perineum, okay? To do that, they may ask you to stop pushing. And if you feel the urge to push, you're gonna think that they're crazy, because when you have that urge, there is nothing stronger, okay? But the reason that they ask you to stop pushing is because they need time to reduce that tissue. They need a time to allow that tissue to stretch. And also, to control the delivery of that head. You don't want it to just pop out, because that will lead to a deeper tear, okay? So if they tell you to stop pushing, you're going to have some kind of relief. So you can pant, or you can blow raspberries, or do horsey lips, but you want to put some energy somewhere, and so you can use those techniques to help you keep from pushing if they ask you to stop, okay? But don't hold your breath. You need oxygen. Okay, how are we doing on time? All right. Variations in the labor process. So these are some things that you may run into, but you may not. And I just mentioned them as a way of you being educated. I want you to be able to know enough to ask questions and make educated decisions. So that's what this portion is about. Induction of labor. That's where you have no signs of labor, but we're going to start and then medically manage your labor process. Okay, so we do this mostly for medical conditions like pregnancy-induced hypertension, or the placenta is not working the way that it should and the baby's no longer getting what he or she needs. There's a lot of different reasons to do medical inductions. We would prefer the baby be at least 39 weeks, if at all possible. They still offer elective inductions, which is, there's no medical reason to do it, but if at all possible, it's best if you allow your body to go into labor on its own. Statistically, you have less medical interventions and less complications. Let's see, there's different ways to induce, and it kind of depends on what's going on in your body. If your cervix is soft and amenable to starting the change of dilation and effacement, then they may bring you in the morning and just do a Pitocin induction. Pitocin is a synthetic form of oxytocin, which is that hormone I mentioned that drives your labor. They start you out, it's an IV medicine, they start you out at a very low dose and they titrate it up until you're in an effective contraction pattern, okay? But they're gonna manage your contractions through that Pitocin, okay? If your cervix is not ripe, it's not really soft, it's not going to be open to changes, even with contractions, then they might bring you in and do a cervical ripening agent. So they usually do that at nighttime. They'll bring you in late and they'll insert a suppository or tablet in the vagina back behind the cervix. As that melts, you have changing in that cervix. It starts to soften up. You know, it sounds kind of gross to describe it this way, but it's similar to putting meat tenderizer on a steak. Okay, it's going to make it softer. When you have this particular induction of labor, when they do the suppository, you've got to stay in bed for a couple of hours to ensure that that's going to stay up in there and do its job. But then usually you can get up and around. Prostin and Cervidil are two of those agents. Those will simply soften the cervix. Cytotec is one that they use, and that one actually can also induce some contractions. So that's the difference in those. They can, let's see, they can usually do that overnight, okay? And then the next morning, they'll start you on Pitocin to induce the labor, okay? We talked about augmenting with an amniotomy or breaking your water. So that's what that little picture at the bottom is showing, that amni hook that I was talking about. Augmentation of labor is you've gone into labor on your own, but you are not making good progress. You've slowed down or you've stopped making changes in your cervix. And so they will utilize usually Pitocin. That's the most common form of augmentation to get those contractions back on track and get that labor going again. But, you know, if your water hasn't broke, they may use the amniotomy as well. How long past the due date is it okay to wait if there are no signs of labor? Because there are complications to waiting too long also. Most doctors will not allow you to go past 41 weeks, just simply because things start to deteriorate. The placenta starts not being effective anymore, and that kind of thing. So 41 weeks is usually the max. Some doctors will let you go to 42, but for the most part, it's usually around 41. And some prefer you at 40 too. So this slide's showing, we prefer babies to be in anterior presentation, that one on the right. It's the easier way for moms to deliver, but they sometimes get into posterior presentation. So, you know, I was talking about that internal rotation they do to get into position, and your positioning being important to help them do that. So if you have a posterior presentation, sometimes positioning can help get that baby turned around. Something like getting in hands and knees, or, you know, just leaning forward can help pull that baby around. I've seen some articles that pose that if you lean forward a lot while you're pregnant, so like you spend time leaning against your kitchen counter, that it may encourage babies to get into the anterior presentation when it's time. I don't know how true that is. That wasn't a study. That was just an article that I read, but I don't think it would hurt to, you know, spend a few minutes leaning forward every day. But if you have a posterior presentation baby, it's going to be more painful in most cases because that very hard head is putting more pressure on your back. So if you hear about back labor, a lot of times it's a posterior presentation baby. But you are not powerless in this situation, and we can certainly deliver a posterior presentation baby. It's just that it may be a longer pushing stage, maybe more painful, just simply because of the way our anatomy works. We call them sunny side up though. The last delivery that I was in on was the sunny side up delivery. Mom delivered like a champ, no problem. But you know, when I was in labor with my first child, my body kept telling me I needed to be in hands and knees. And I'd worked on the unit. I'd I was a postpartum nurse, but I worked in a labor and delivery unit, and I helped with a lot of deliveries at the time. I'd never seen a woman on her hands and knees in labor. And so I just thought I was crazy. But I know now that had I listened to my body and gotten in hands and knees, I might have been able to help Avery turn into an anterior presentation. My body was telling me that I needed to. I just didn't know to listen to it. Okay, here's the slide of the perineum I was talking about earlier. Okay, and this is showing where they do episiotomy incisions. They can either go down the midline, or they can go medial lateral, which off to the side, and they can do either side. Okay. Prior to an episiotomy, that is a medical intervention. They should get your permission to do it prior. They use these more commonly if they need to do forceps or vacuum extractor. If the baby is just right there and we're trying to deliver and avoid a C-section, then sometimes they'll do, episiotomy or forceps or vacuum extractor to help mom along. But like I said earlier, it can increase the risk of tearing deeper. It's a little bit harder to recover from, so we don't routinely do them anymore. Now, that being said, there is a way to help the perineum be more stretchy. 36 weeks, you can start doing pelvic perineal stretching exercises. This will probably require your partner to help you out, and you need lube. And you just lube up the tips of the fingers. It's not the whole finger, but a couple of fingers, just the tips. You lube up with your favorite lube of choice, and you insert just those tips, and you massage back and forth until, well, while you're pulling down towards the rectum, and you massage until it starts to burn. Okay, and then you stop. You do that once a day. And as you continue to do that day by day, the perineum is going to become more and more stretchy. Now, a lot of people look at me like I'm nuts, and you don't have to do this. It's absolutely optional. But if you're one of those ladies that's really afraid of tearing, doing that little stretching exercise may help prevent tearing, or at least minimize the amount of tearing that you have. So this is showing the forceps and the vacuum extraction. This is something I also don't see nearly as often as I used to. I don't have the statistics with me, but we do around 230 births a month, and I see usually 6, 7 of these, maybe 8. Not near as many as I used to back when I first started. Forceps and vacuum extraction, people think they're pulling the baby out, and they're not. The goal of this is to offer gentle downward traction as mom is pushing. Okay. They use these in the case of maternal exhaustion, where mom is just not really effectively got enough push to deliver on her own, or if mom is unable to push the baby below that pelvic arch. You see that bone that's cut away in the little diagram there. They basically are doing this to try to avoid a C-section when you're right there. Forceps and vacuum most doctors don't do both. They'll do either or, certainly not both in one delivery, but they usually prefer one or the other. So if you're afraid of this, or you're just curious, ask your doctor what they do. But forceps will cause bruising to the side of the baby's face. It will cause more bruising to mom's bottom. So both of you will be a little more sore. Baby will be a little more sluggish, usually the first day. I worked lactation for several years before becoming the childbirth educator, and my forceps and vacuum extraction babies were a little sluggish to start breastfeeding, just simply because I think they're tired. This is a more traumatic delivery, and the forceps babies, I think their jaw is a little sore because of the placement of the forceps. But they perk up and they come back around. But they may have bruising on the sides of the face for forceps and the top of the head for the vacuum assisted. With the vacuum assisted, they can release the vacuum between contractions if they need to. There is a vacuum release. if the vacuum pops off, they can only apply it 2 more times, so it's not continuously applied over and over and over again, causing tremendous amounts of bruising. But gentle downward traction is the goal here, not actually pulling the baby out. If you want to read about this, please look up evidence-based, research-based info. Don't Google it. Don't look at mommy blogs, because it will haunt your nightmares. You know, and you just don't know what's true on the internet, but medically based studies and research is more reliable because it's, you know, definitely truth. This is an intrauterine pressure catheter. This is another way of monitoring. We monitor all moms and babies externally. Okay, so we got those stretchy straps on your belly, one on top of your uterus to see what the contractions are doing, and then the toco wherever the baby's back is, so we can monitor their heart rate. Now, if we're seeing a different, you know, you're telling us contractions are one way and the monitor's not really showing us that pattern or whatever, or intensity, then they may want to do an intrauterine pressure catheter. They also use these more often in inductions to help track contractions. Of course, your water has to be broken. This is applied with the sterile vaginal exam. Another benefit to the intrauterine pressure catheters, you see that clear port, that can be used to infuse sterile fluid if we've got meconium staining. So, you know, if your amniotic fluid is green or brown, and you know, it can thin it out and make it a little easier for the baby. So they might want to do that as well. Fetal scalp electrode is the internal monitor for baby. And if we're not getting a good trace of baby's heart rate, or if we're seeing a lot of decelerations in the heart rate that are beyond what we expect, then they may want to do internal monitoring for the baby. This is a little screw electrode. It goes just underneath the skin of the scalp, and it's a much more accurate picture of their fetal heart rate. It will leave a little pinprick sore on the scalp, but it's not deep. It's just a tiny little pinprick. But it is a much more accurate way of seeing the baby's heart rate, and it's applied the same way, sterile vaginal exam. Medicated pain management. There are a few options. IV narcotics are one. This is one that is temporary. It's probably not going to be effective multiple times. You know, you can take it a couple times, but then after that, it becomes less effective. You kind of habituate to it, and you don't get the relief that you did with the first dose. But it will take the intensity of the contraction down. It will make it seem shorter. So it might be an answer if you're just needing a break and wanting to rest between contractions a little bit better, if you're not wanting an epidural. It's IV, so of course it's in your bloodstream, which means that it will go to the baby. So we don't want to give it too close to the time of delivery. If we give it too close to when the baby delivers, we can counteract it with Narcan, but we do monitor and watch and make sure that we're not giving it too close to the time of delivery. Now, sometimes babies surprise us, and those babies usually will need more stimulation, maybe some oxygen, maybe some Narcan, more interventions to kind of get them going. But for the most part, we're very careful about when we give IV narcotics. It's just something to take the edge off. And that being said, you cannot sign a consent for anything after receiving narcotics for 4 hours. So make sure that you've got everything signed that you need to sign. You know, if you've been on the fence about an epidural and you didn't sign a permit and then you've had narcotics, you can't sign that permit for 4 hours. So just keep that in mind. Local is what it sounds like. It's just simply numbing up that one spot of your perineum so that you can either deliver the head of the baby. Some people want to be numb for that, or for stitches for perineal repair. So this is similar to when you get a shot at the dentist to numb up your tooth. It's just that one area that's numbed. This is using lidocaine, and it will be along the vaginal sidewall to numb up your perineum, and it wears off quickly. It's not going to affect your ability to walk. It's just a temporary, very localized anesthesia. The one everybody wants to know about is epidural. Okay, an epidural is a medical procedure. It does require a separate consent. We use certified registered nurse anesthetists at Midland Memorial for all of our anesthesia in labor and delivery, and they're dedicated to our unit. It's all that they do. There's one there at all times, but if it's real busy, there'll be two there. When it comes to deciding when to get an epidural, have good communication with your labor and delivery nurse. I can't tell you like a number of dilation when you can get your epidural. It really depends on your labor progress. You know, the longer you can hold off, the better, you know, because medical intervention begets medical intervention. But, you know, ask for it when you're ready, basically, is what I'm going to tell you. We want to be in an active labor with contractions that are in a good pattern, if at all possible. But, you know, when you're ready, ask for it. And when it comes to when's too late to have an epidural, I can't tell you a number of dilation for that either, because that also depends on your progress. If you're moving along at a steady pace and slow, you know, and you get to an 8 and decide, okay, I need an epidural, then you probably are going to be able to get one. But if you're moving along really fast and you get to a 6 and you want an epidural, it may not be able to be timed for one. So it just depends on you and your labor progress. How late is too late, you know, everybody's different. Now, because this is a medical procedure, there's, of course, are side effects. You may not get the level of control of pain that you'd like, which they can work with. So let them know that you need some adjustments. You may have some tingling pain, like if the catheter moves up close to a nerve root, it may give you that pins and needles feeling. What else? You may get more numb on one side than the other, which they can also work with. Sometimes just changing your position will help with that. Once they have done this procedure, it takes about 15 minutes to fully get pain relief, and you know, adjustments can be made as needed. They give you a bolus dose of medication, and then it's a continuous flow that's attached to an epidural pump. The procedure itself, they'll either have you sit on the side of the bed like this mom is here, or they'll have you lay on your side and curl up. You're going to lean over or curl up so that they can get where they need to go for the epidural. People are always afraid they're going to get paralyzed, but this is done below the spinal cord. So, you know, really unlikely. If you have questions, deep questions about side effects and stuff, you can call labor and delivery and ask to talk to one of the CRNAs. You know, I'm not a CRNA, so I'm not really qualified to go in depth about it, but, you know, they certainly can, you know, and I've had moms that have had history of back injury and things like that, and they wanted to talk to someone, so you can certainly call labor and delivery now. The risk factor on there, the spinal headache, that's a rare complication of epidural and spinal anesthesia, but it's a very specific kind of headache. And I mention it in class simply because if you have this headache, I want you to be seen before you go home. So you'll need to see the CRNA prior to going home, because if you have a spinal headache, it will take weeks to go away without treatment. They can give you fluids, they can give you caffeine, but the blood patch that's mentioned there, that's the actual cure for a spinal headache. So if you have this kind of headache, you know, and the headache is very specific in that if you lay down, you feel fine, but when you sit up, it is a pounding, horrible headache. You know, I've not had one, so I'm not sure exactly what it feels like, but I've had moms describe it as similar to migraine pain. So make sure that if you have a headache after an epidural or spinal, that you will call for the CRNA to come see you. But the blood patch, the procedure for an epidural, they sit you on the side of the bed, they sterile drape you, they clean you with soap, they sterile drape you, they give you a lidocaine shot, they induce the epidural needle, and then insert the catheter. They pull the needle out, and then they tape it all up and attach the catheter to your epidural pump. When you have to have a blood patch, the procedure is similar, except for instead of hooking you up with the epidural catheter and the medication, they actually take blood from your arm and put that in the epidural space, and that helps to alleviate the headache. Okay. This little graphic's just showing where that catheter goes. It goes in between the dura, okay, which are the coverings of our brain and spinal cord, all that stuff. The medication infuses there, and it numbs us up. That's another one showing where the epidural space is. It numbs us up from our diaphragm down, so we can still breathe, but we do not have normal feeling. You do sometimes have feeling a little bit, but you don't have good control of your legs, but you do have some control in most cases. It will take a couple of hours to wear off after the epidural is turned off, so you will need help moving around for a while. And when you feel like it's completely worn off, you still need to call for help when you get up to the bathroom the first couple of times. And I want you to have all of your feeling back, even if you are like, oh, well, it's just my pinky toe on my left foot that still feels numb. Please don't get up out of bed until you have all of your feeling back, because I have had moms try to get up and kind of buckle on me. You want to make sure that you talk with your nurse before you try to get up after the epidural. Spinal is a similar procedure to getting an epidural, but this is a heavier dose of medication. It's a one-time dose. They don't leave the catheter in, and this is what we use for our C-sections. Now, I've had both. I've had an epidural and a spinal, and with the epidural, I had some movement in my legs, although I had bad control. With a spinal, you have no movement. It's very heavy, but that is necessary because they're going to do a C-section. Once it's introduced, they will check you with something sharp to make sure that you don't have feeling. It will take away pain sensation, but you may still feel pressure. With my C-section, I definitely could feel pressure, but it was not painful. So I like to mention it because some people kind of think the pressure and pain are the same thing, and if they feel pressure, they're going to feel pain, but it's different nerve endings. So if you feel pressure, it's okay, but if you feel pain, you need to tell them right away. Spinal also takes a while to come out from. With epidural and spinal, for that matter, you're going to have a catheter in your bladder to drain it, because you're not going to be able to tell when you are needing to go to the bathroom. And then with a C-section, of course, you're going to keep the catheter for a while. With a vaginal delivery, you don't necessarily need the catheter after delivery. You usually can pee within a couple of hours afterwards without needing the catheter. General is our kind of last resort anesthesia for C-sections. We like to do spinals because it's more baby friendly and mommy friendly and partner friendly, for that matter. With the spinal, baby doesn't get the dose of medication. Partner can be in the OR with you guys. With a general, if we're not real fast, baby can get the effects of the general. And partner cannot be in the OR with you, but this is where we knock mom out and do the C-section, and then you guys can come back together in the recovery room. But we don't allow support people in the OR for that particular anesthesia. And we use it in the case a spinal doesn't work, or if it's an emergency and we don't have time for a spinal, or if mom has contraindication to having a spinal. So after delivery, we're talking vaginal delivery here. Baby's going to go to your chest. That's the best place for them to transition. We're, of course, going to dry them off because a wet baby is a cold baby. We're going to do our APGAR scoring, which is kind of baby's first report card. We rate them at 1 in 5 minutes for those 5 characteristics there. Usually count off for color. It is normal for a baby to have purple hands and feet or dusky looking hands and feet for a while. So very rare do you ever see a perfect 10 for an APGAR, but usually 8-9 or 9-9 are what we see. Baby's doing poorly, they'll do another one at 10 minutes. But of course they're intervening for the baby during that time. And a vaginal delivery partner will be offered the opportunity to cut the cord. You don't have to. You don't have to turn in your man card. I had a dad ask one time, if I don't want to do that, do I have to turn in my man card? You don't have to do that. It's not necessarily for everybody, but it's kind of cool if you're the kind of person that likes that. Recovery, you will stay in labor and delivery for a couple of hours. Baby will stay with you unless there's some medical need to take them to NICU. But you will be monitored closely during that period of time. They're going to be checking your uterus to make sure it's good and tight and contracted. You make sure your bleeding is not too heavy. They're going to be checking your vital signs, checking baby's vital signs, and just be monitoring you for a couple hours. And then you'll go to their mother baby unit, and you guys will stay with us for 24 to 48 hours post delivery for a vaginal, or 48 to 72 hours for a C-section. I mentioned, we do that skin to skin time immediately at delivery because it's the best transition place for babies. Their vital signs are better, their blood sugars are better, they cry less, they start seeking the breast because they need the calories. They don't have their umbilical cord anymore, so they're going to need a little boost to something, and so they can smell your breast and your colostrum, which is the first milk, when they're on your chest, and so it's just a great way to initiate breastfeeding. If you're allowed visitors during the time when you deliver, we don't require, but we encourage you to limit visitors just during the golden hour, because it's family bonding time and it's where that baby's transitioning, and it's best for them to be on mom's chest. It's entirely up to you though, if visitation is allowed at that point. Immediately postpartum, you have more shifting in hormones, so you may have that trembling or hot flashes or chills show back up. You're going to be hungry and thirsty, but I encourage you to start out slow, sip on some water or juice before you just guzzle, because nausea and vomiting can show up again. Crackers first, and then you can dig into something a little bit more hearty, because you sure don't want to see a jalapeno cheeseburger again if you can avoid it. Lochia is the bleeding that I was talking about, vaginal bleeding. It will last up to 6 weeks. But it will transition immediately. It's pretty bright red, and then it transitions to the brownish, and then a pinkish, and then a whitish discharge. Fundal massage is that checking of your uterus. The fundus is that top of your uterus, and we do massage. It is uncomfortable. You may have to kind of breathe while we're massaging to make sure that that uterus is good and tight. We want it to stay tight, and it should be below your belly button. If it gets really soft and boggy, then your bleeding is going to increase. So we want to make sure it stays tight. They'll give you some medication after the delivery of the placenta to help tighten it up. They will do fundal massage, which helps tighten it up, but also they'll teach you fundal massage as well so that you can do it. You can massage deeper than we can without it hurting as much for some reason. That's just how humans work. But when it comes to fundal massage, when you feel at your belly button, it should be a little either at your belly button or a couple of fingers below, and it feels kind of like a softball in your belly. It'll take a full 6 weeks for your uterus to get back down to its normal size, though. You will have cramping pain afterwards as that uterus is going back down to size. The first week is usually the worst of that, and it may be worse when you breastfeed because you have that release of oxytocin, which is that hormone that causes your uterus to contract. Your perineum will need to be kept clean. They'll give you a peri bottle to wash it with warm water every time you go to the bathroom. You're going to pat dry instead of rubbing. Even if you don't have stitches, you may have some little micro tears, so you're going to be very gentle with your bottom. Any stitches that they do will dissolve on their own. You don't have to have them taken out, but you do need to see your doctor in 6 weeks for a full checkup, and they'll check and make sure everything looks good. We do ice packs for the first 24 hours to reduce swelling of your perineum, and then afterwards the heat can be helpful, so you can get in our showers and use the handheld shower head and run that water front to back for several minutes. And then at home, you have one of those handheld shower heads, you can do that, or you can get in a tub of water that's a couple inches deep. Warm water will help to heal your bottom. Or if you want, they can send you home with a sitz bath They do still have them. I understand they have to order them from CS. So if you're interested in taking one home, you can ask for it. Some other interventions that they may, that they will offer you are dermaplast spray for your bottom, which is a numbing spray. It's the same stuff you would use on a sunburn. Tux pads, which are witch hazel pads that can reduce swelling, especially in hemorrhoids. If you've got hemorrhoids, they may give you a hydrocortisone cream to put on your hemorrhoids as well. You should be able to empty your bladder within about 3 to 4 hours after you deliver. Bowel function will be sluggish to return, but usually within a couple of days. If you've had a tear or stitches, they probably will put you on a stool softener, so I do encourage you to take those. But make sure that you're getting plenty of fluids and plenty of fiber in your diet, because that will help your bowels become more regular again. Your breasts will change. They'll start to fill with milk about day 3 on average, but anywhere from day 2 to day 5. If you're breastfeeding, then you need to breastfeed as often as you possibly can. Massage those breasts while you breastfeed during the engorgement phase. And you can do moist heat to the breast before feedings and ice packs to the breast after feedings for about 5 minutes to help reduce the, the ice helps reduce the swelling, but the warmth may help open up the ducts and get that discomfort out of the way, or gets that milk out of the way of the ducts so that you're more comfortable. So heat before, massage during, ice afterwards during engorgement will help you get past it, and then nursing as often as you possibly can. Bras are very important. You want to wear a supportive bra, but non-underwire. For the first couple of weeks, you'll need it for 24 hours a day. Usually after the first couple of weeks, then you can ease back on wearing it at night. But the girls need support, so make sure once you get to postpartum, you get your bra on. If you're not breastfeeding, you need to ask for ice packs, and you need to pack your breasts in ice for 15 minutes at a time. I would do 8 to 10 times a day to help discourage milk production. No sex, no douching, no tampons, nothing in the vagina for 6 full weeks until your doctor sees you and says everything's cool. Okay, you do not want to introduce the possibility of infection. It can lead to tissue breakdown. You just don't want to do that. So make sure everything is a-okay with doc before introducing anything down there. You're going to go through a lot of different emotions. You'll run the gamut. Initially, you may feel excited, or you may feel exhausted, or you may feel a little disappointed if you didn't have the labor experience you were expecting. You may be just elated. Everything and anything goes when you've had a baby. We expect the first couple of weeks there to be some postpartum blues. As your hormones are equalizing themselves and normalizing, you will have ups and downs. And it should be fleeting. It will come and go. 80% of moms experience some form of postpartum blues. Usually by the end of week 2, they're gone. Now, 1 in 7 moms and even 1 in 10 dads can experience postpartum mood disorder, which can be anything from depression to anxiety. I've got a long list of emotions and behaviors that can be a part of postpartum mood issues. And if you start to experience any of this, this is extreme, this doesn't go away. It can be intense fear of leaving the baby. It can be disinterest in interacting with anybody. It can be just out and out sadness. It can be a lot of different things, but if it's not normal for you, and if it's not fleeting, it's staying and hanging around, you need to let your doctor know. Ladies, your OB is your first line of defense from postpartum mood issues. Guys, you need to see your primary care provider if you're experiencing some of this, because it's very real for dads too. Sometimes you just need to be monitored, and sometimes you need medication, and sometimes you need counseling. So don't be afraid to ask for help. I'm passionate about that because I experienced it. I went through postpartum depression and anxiety for 8 months after I had my first child. It probably would have been a lot shorter had I asked for help. I was ashamed, I was afraid, and I didn't say a word to anybody, and I suffered. So please don't do that to yourself. Ask for help if you need it. C-section are about a third of our deliveries. I believe I mentioned that. We would like it to be lower. Midland Memorial, last I checked, was around 28%, so a little less than what I have listed there. Common reasons for C-section are fetal distress most often, or failure to progress where mom is just stalled out in labor and it's not continuing to make progress. If mom is having medical conditions, or if baby, the fetal distress is from baby not tolerating labor anymore. They're exhausted. Malpresentation, of course, most commonly breech, but we can have like this guy who's got a shoulder presentation. I've seen hand presentations. I've seen foot presentations. If they're not in a position that's conducive to delivery through a pelvis, then it's going to have to be a C-section. Placenta previa, you usually know now because we do sonograms, that that's happening. And if that placenta is over the cervical opening, you can't deliver a baby through it. Umbilical cord prolapse, that's an absolute emergency and very rare. But if it were to happen, you've brought water breaks and you feel umbilical cord come through, then we need to get that baby delivered right away. You call 911, you get to where you've got your butt above your head so that you're not compressing that cord, and we need to get that baby delivered immediately. An abruption, abruptio placenta or placental abruption, is where the placenta separates from the sidewall of the uterus. It can be partial or it can be full. In either case, both mom and baby are in trouble because you're both bleeding. So that complication I mentioned where the abdomen is extremely firm, not like a contraction, but just hard, and you're having bright red vaginal bleeding, that's a symptom of an abruption. Also very rare. When we go to do C-section, CRNAs are going to come in and do health history with you. They're going to do pre-op assessment, and they're going to give you medication. We'll shave your belly just with the clippers to get any stray hairs out of the way. You'll have a catheter in your bladder. They're going to put sequential compression devices on your legs to massage the blood flow back to your heart because we don't want clots. You're not going to be moving around a lot for the first 24 hours. This is just showing mom on the OR table. She's got her arms on the arm board. It's got a little O2 going on, got her heart monitors on, she's got blood pressure cuff, O2 sat monitor. Partner's right there taking the picture, and anesthesia's at her head. Everything beyond on the other side of that blue drape is sterile field. This is showing the incisions. We do the one on the right, most commonly the low transverse. Classical on the left is usually only done in emergencies, absolute emergencies, or if mom has a previous classical incision from a prior surgery. This graphic's just showing the doctor pulling that head. The head was down in the pelvis, and so they've reached in and they're pulling that head through the incision, and someone is offering counter pressure on the other side. There's the emergence from the incision site. Little Lion King action there. So when you have a C-section, your recovery will also be 6 weeks, but it's going to be a little bit different in that you're recovering from delivering a baby, but also from an abdominal surgery. So you will be more sore. You probably will need more pain medication than you would have with a vaginal delivery. It's important. You're going to be in bed for the first day or so, about 18 to 20 hours, and then they're going to start getting you up, and getting up and moving around is essential to your recovery. You will need to get up and walk in the hallways in the hospital at least 3 times a day. You will need to get up and move around when you're at home, because if you sit static, for one, it increases your risk of clots, but for 2, it makes it more painful if you don't move around. So not overdoing, but actually just moving around will help you to recover faster. We want to make sure the incision site is well cared for. Some of you will go home with a bandage that stays on until you see your doctor. Some of you will have the bandage removed prior to going home. Some will have staples, some will have sutures. They'll give you specific instructions based on what your actual needs are when you leave the hospital. But you can shower. When you shower, you want to make sure you're using new washcloth and new towel every time, because we don't want to introduce bacteria. Any, we like to save water these days and reuse towels, but this is not the time for it. Any spongy things like the little squishies we use with our Bath and Body Works or loofahs, they all harbor bacteria, so now is not the time for those either. You don't want to use a bar soap either, because that can harbor bacteria as well. So liquid soap, new washcloth every time. When you go to look at your incision or care for your incision, you want to make sure your hands are very clean, or if you have a partner helping you, make sure their hands are clean. You want to make sure the incision gets air. A lot of times after we have a baby, we have a little skin flap where that pregnancy was, and it folds over our C-section incision. So make sure you're pulling that up and allowing air to circulate around your incision several times a day. If it gets really sweaty in there, you may have to clean it, and just make sure you pat it dry and let it dry fully. All of those things will help reduce post-op infection. If you develop, it's going to be tender, but if you develop worsening pain, copious amounts of drainage or foul-smelling drainage from the incision site, if the edges of the incision will look a little bit red as it heals, but if there's redness beyond that, or red streaks on your belly or in your pubic area, or if it's hot to the touch or looks extremely swollen, those are all signs of infection, and you need to call your doctor right away. All right. So that's the fast and furious version of basic childbirth class. I hope that it was educational and not too overwhelming. I'm done with my presentation, but I'm happy to answer questions if you guys have questions. You can type them in the chat, or you can unmute them, unmute your mics and ask them. I'll hang out for a little while. I'm happy to help in any way that I can. If you think of questions after we're done here today, please email me, childbirtheducation@midlandhealth.org, or you can call me 221-3283, and I'm happy to do anything that I can to help you feel more comfortable and more educated. Thanks for coming.